Just so we don't get too far behind, if people can take their seats, and we're going to get going. So I want to introduce Henry Allen. Henry Allen is the senior attorney for advocacy at the American Medical Association, and he's been very involved in antitrust legislation. He's testified before the federal government in antitrust and has been part of a number of landmark legislations on antitrust. Now is an attorney with the American Medical Association and will be sharing some of his perspective with us. Is also a professor through Northwestern. So and Henry was one of the people who helped me organize this. Having people like Edward Hughes and Michael Vandorf, who you'll meet, is really Henry's contact. So Henry, I thank you very much, and I'm going to let you speak.
Well, this is an honor. I'm going to dive right into some topics of the day. As you know, there's the speculation that the big five health insurers are doing a dance to conclude some merger negotiations. We know that Aetna has announced that it has a merger agreement with Humana, and Anthem is interested in acquiring Cigna, and we also understand that United Healthcare still has its eyes on Aetna. So we have the five health insurers engaged in these negotiation discussions, and the Federal Trade Commission and the Department of Justice will be reviewing these and asking for your reactions to these proposed mergers in your marketplaces. And obviously we'll be consulting with the American Medical Association, American Hospital Association, and others. So, the questions that the government's going to ask about these prospective mergers is basically whether the mergers will allow the health insurers to acquire and exercise market power. And what are the marketplaces? Well, one obvious marketplace, is the area in which beneficiaries, employers, consumers shop for health insurance. What's the effect on that marketplace? But equally important is the effect on the marketplace for providers of services, physicians. What effect would a merger of Aetna and Humana have on what ultimately you are paid for your services? And will that payment be below competitive levels? So the first, where everybody starts is, looking at the current level of competition in the health insurer marketplace to assess whether the merger will allow health insurers to acquire market power, either unilaterally, the way they price their services to consumers, or coordinate, as we're observing in the airline industry, coordinate with health insurers because of the few players. The FTC, the DOJ, the Department of Justice, is the agency that really looks at health insurance mergers. The FTC tends to concentrate more on what's happening in the physician marketplace and with respect to hospitals. And the DOJ will challenge the Aetna acquisition of Humana or any of the others if it will significantly increase concentration and lead to a moderately or highly concentrated health insurance market. So what does the marketplace look like today? Is it already highly concentrated? Well, for that, everyone actually uses the American Medical Association study of health insurance markets. We have the resource that frankly, all the players want to use when looking at what the market looks like today. And what our report has shown in our most recent report of the market in 2014 is that 72% of the 388 metropolitan areas studied are highly concentrated, meaning that there is a significant absence of competition already in the marketplace. There are few competitors, few health insurers, and they have large market shares. Look at this number, or these results. 90% of metropolitan area studies, in 90% of them, at least one insurer held the commercial market share of 30% or greater. To an antitrust lawyer, that's a significant share. That's something that raises red flags. But in 41%, a single insurer had a market share of at least 50%. In 9%, a full 36 of metropolitan statistical areas, one insurer had a market share of 70%. What does that mean? That in about 10% of metropolitan areas, a health insurer is already a monopolist. So you can imagine if these 5 players already occupy a monopoly, whether the DOJ should be approving the merger in that market. And as you probably all realize is that the mergers will be evaluated on a market-by-market basis. And we'd like to think that not only will the DOJ be concerned about Chicago versus New York versus Billings, Montana, geographically, but also look at the market for provider services, for physician services, and what a merger will mean to the reimbursement of doctors in each particular market. And I should say, one of the things about this, one of the things that's really changed since the DOJ reviewed mergers a number of years ago, because there's been the merger marketplace has been quiet in health insurance for years now. And I had assumed that that's because they all realize that the DOJ is not likely to be approving. Go ahead. In my opinion, over the last few years, the pace of the mergers has not been what it had been in earlier years, and here's why I think that that's the case. First of all, our studies have shown the markets are already highly concentrated, and secondly, there's been an evolution in the thinking about health insurance markets in the sense that it had been assumed that there were low barriers to entry to health insurance, that if a health insurer ever raised its prices to a monopoly level or cut back on physician and hospital payments to a below competitive level, that another health insurer would be able to come into the market, build a network, and market in competition. Well, it turns out that these health insurance shares are very durable, that the monopolist has a built-in advantage, has a built-in network, can extract concessions from providers, and it gives it, because of its size, a durable market advantage, cost advantage that the new entrant can't match. Okay, yeah. Well, so and we have observed that these marketplaces have, over the last few years, have become more concentrated. But my impression, and that of some of the health economists that we deal with, that's not been because of recent mergers, but because of people leaving the marketplace and just abandoning it to a competitor, and the size of that competitor gets larger. Also, what has happened in recent years, fortunately, is that the Affordable Care Act has introduced health insurance exchanges, and there's been a real emphasis on getting competition in these marketplaces. And I had thought that everyone was on the same page, that we needed to fix this, and we wouldn't be seeing these mergers. And lo and behold, these 5 insurers are coming at us with their proposed mergers. So we have to ask the question then, what is the effect on the consumer marketplace when health insurers merge? And Lee Moore-Daphne and others that works with us works with Professor Hughes at Kellogg has done a wonderful study showing that health insurance premiums actually do increase as a result of the merger that she studied. And that what you're going to hear from the health insurers is that there are efficiencies in growing larger, but the evidence, the empirical evidence that's out there, says that they do when they gain a large market share, things happen in this marketplace the way you would predict in other markets. They exercise market power, they raise prices. Now, this is what should interest everybody in this room in particular, and that is that the mergers also result in lower than competitive reimbursements to providers of services. That it thereby reduces the quality and quantity of healthcare services in a marketplace when health insurers can drive reimbursements to below what you would expect in a competitive market. And so this has been a big sea change at DOJ. Not only have they recognized that there are high barriers to entry, but they've also recognized that that what happens to physician services is a big concern. And they therefore, in the Aetna acquisition of Prudential, the DOJ blocked a portion of that merger on the basis of its effect in the physician marketplace. They predicted that it would have anti-competitive effects, and therefore Aetna was told to stand back from its acquisition of Prudential in the Dallas and Houston markets. The same result occurred in a later merger of United and Pacific Care. And then finally, the recent merger of 2010, if that's what you mean by recent, there was one that was announced between Blue Cross Blue Shield of Michigan and the Physicians Health Plan in mid-Michigan in 2010. And I love this language from the Justice Department. They blocked that merger because it would have given Blue Cross Michigan the ability to control physician reimbursement rates in a manner that could harm the quality of health care delivered to consumers. So that was awesome. All right. We also have the rapidly consolidating hospital markets. And we've heard that, the big push for clinical integration, for delivering value-based care has created a need for hospitals to merge. And that's why we've seen a rapidly consolidating hospital market. But as we say here in this slide, actually that was occurring prior to the Affordable Care Act. And that there were 247 hospitals merging in 2012, and that was 3 times the number in 2008. And we do have a problem of consolidating hospital markets. The AMA has been concerned about this consolidation, has expressed a concern in the United States Supreme Court. We filed a brief there where in that particular case, there were 2 hospitals that wanted to merge into a monopoly in Georgia, in Athens, Georgia, in Albany, Georgia. And the FTC was arguing that the merger was anti-competitive, found that it was anti-competitive, blocked the merger. Then there was a technical defense called the state action immunity defense, state action defense that was raised. And so the case went to the Supreme Court. But the AMA used it as an occasion to let the country know, basically, that we had a concern with hospitals acquiring monopsony power in physician markets, such that physicians could not get hospitals to compete with one another for physicians, and would would basically create a company store marketplace where physicians had no place to turn. And we expressed that monopsony concern, and the Supreme Court, by the way, found that the FTC could block the merger of the 2 hospitals. So with that concern, we've also been working to increase physician-driven entry into hospital markets. And one of the things that we've argued is that the government, the federal government, should go into each state and try to get the states to repeal their certificate of need laws. Because what we've determined, and others have determined, is that the certificate of need laws have been used by, frankly, the hospital industry. Mike, I hope that maybe, I don't want to offend our hospital audience here, but it's been used to prevent physicians from competing with hospitals in outpatient markets. And some 37, 38 states still have these certificate of need laws on the books, and it exists here in Illinois. And the AMA has testified here in Illinois to the effect that Illinois should repeal its certificate of need. We've also recently complained that while the Affordable Care Act has been interested in getting competition in healthcare markets, ironically or paradoxically, the Affordable Care Act had a provision that prevents physicians from acquiring hospitals from, you're nodding your head back there, you're aware of that, from developing specialty hospitals. And that is really quite an amazing decision in the act to do that, because the specialty hospitals have had a remarkable record for quality, that when the government goes out and looks at, compares the quality of hospitals, I think the top 10 quality institutions were all physician-owned. And a huge portion of the top 100 hospitals were physician-owned, despite the fact that there really weren't all that many physician-owned hospitals in the marketplace. But the Affordable Care Act basically now says that when physicians own a hospital and they refer patients to that hospital, it's a form of self-referral that is no longer exempted from START, from the self-referral provisions in START. And why do you think physician-owned specialty hospitals would be a great source of new competition in hospital markets? What makes them so effective, do you think? Are there sound reasons why physician-owned ambulatory surgical centers, physician-owned hospitals are more efficient than others? Does ownership matter? It turns out when the government studied, when Medicare studied these institutions, they wrote a report saying that they were amazed at how the staff of these institutions all believed that the fact that their ownership, the physicians were concerned about the quality, that ownership really mattered, and they were all motivated to give high quality care. What's the other reason why physician-owned hospitals and outpatient facilities are more, you would expect to find them at the top of the quality list? Well, I guess in the absence, that's right. Had they not been in the marketplace, with the lack of competition, would have caused the hospitals not to respond. And you're right, they did find that the government found that upon the entry of the specialty hospitals, and ambulatory surgical facilities, that the community hospital, the general counsel's quality of care actually did improve. Huh? Watch your cost. Yeah, watch your cost. What? What's about the acuity and the demographics of the patients? Oh, so that is, yeah. So they controlled for that. There were several huge studies, all, by the way, undertaken at the request of the American Hospital Association, because their membership was complaining that physicians were self-referring and the sickest patients, but after controlling for that, it turns out that the quality was still higher. But so what's the operational reason for it? Well, it's specialization, right? It turns out that these are focused workshops, and many of the health economists who have studied this have talked about focused factories. And then there's a famous health economist at Harvard whose name I can't think of now, and he wrote that the factory, the hospital, is the hospital as a factory is the only one that is not focused. That in the United States, that hospital, the fact that they're generalists and not specialized makes them unique in the world of factories. There are advantages in being specialized, and I have here. Okay. Sorry. Okay. So the other thing that we've done is that we've encouraged the entry of physician-controlled ACOs. And you're all familiar with the federal ACO program, which is a Medicare shared savings program. But if you think of ACOs as being a form of clinical integration, and a new provider, a clinically integrated provider is introduced into the marketplace, these organizations that could be a physician independent practice association can participate in the bundled care program and all the other trends that are out there to deliver value-based care. And the advantage in terms of competition is that not only do you have a physician-driven entry, but these organizations are done on a contractual basis. Providers make an agreements to come together to form a clinically integrated organization, but they're not mergers. Mergers tend to be permanent, durable, but these integrations, because it can be experimental and on a contractual basis, if they don't work, it can be torn up and you don't have the consolidation occurring in the marketplace. And so we've been encouraging physicians to form ACOs, and it turns out that the number of physician-led accountable care organizations has recently surpassed the number led by hospitals. And again, why it turns out that they are more efficient, that the ones that have performed the best in the yeah, thanks. Okay, the ones that have performed performed the best. Are you all right? There's a doctor in the house. Have been the physician-controlled ACOs. And so what's the reason for it? Why are the physician-controlled ACOs more efficient than those that are controlled by hospitals? What's been the research on that? Well, it is that these ACOs that are physician-controlled have an incentive to control hospital admissions, hospital costs. And one of the areas in which we expect to get savings is reduced hospitalization. And there have been some dramatic success stories. The Mesa County Medical Society in Grand Junction, Colorado, has actually had the two hospitals competing for the contract of the society to be part of their ACO, and they've been celebrated as being one of the most efficient ACOs in the country. And President Obama went out there to call attention to what physicians can do when they form clinical integrations. All right, so with these developments in healthcare, what's been happening to physician practices? And I think it's interesting. If you look, this I don't know how many of you have seen the AMA's recently announced study of what the demographics are of physician practices. But you can see that wholly owned by hospital, has been inching up. Practices of direct hospital employees, sort of inching up. But how many are surprised by the low percentage of physicians who are actually directly employed by hospitals. It's only 7%. You're surprised, aren't you, by that number? You get, from reading in the media, you get the impression that the overwhelming number of doctors are now controlled by hospitals, but that's not the case. 60% of physician practices are wholly owned by physicians.
Excuse me, is there a,
Yeah.
do you have a breakdown on who that 7% is? Are they specialists like we are in this room, or are they?
You know, I do have that. I have it in my briefcase, and why don't you, if you're interested in that, you'll take a peek at it. Okay. Okay. Then look at the distribution of practice sizes. I'm also surprised that the majority of physicians in the country, majority of them, practice in firms of 10 or less. And, you know, coming from a law firm, I was in a law firm for 30 years, and I'm used to seeing hundreds of colleagues in my firm, and physician practices are much more intimate. Okay. Still, we do see physicians going into hospitals. If I go back to the other slide, you can see that the number of solo practices have declined. Okay, and so the AMA did a work with RAND to survey physicians to find out why they were merging into larger practice settings. And I have to read this to you. We'll just read it because it's very, very illuminating about the concern in the physician community. Physicians are affiliating or merging with other physician practices or aligning with or becoming owned by hospitals in response to new payment models. From the practice leader perspective, these mergers were to enhance the ability to make the capital investments required to succeed in certain alternative payment models. Bundled payments, value-based care, the move from fee-for-service. And then the investment that's required for computers and data infrastructure. And then also they're merging to negotiate contracts with health plans, including the terms on the performance measures and targets that would be included. And the physicians feel that they want to gain a sense of safety in numbers. Leaders and physicians in multiple practices describe uncertainty about how they would fare in alternative payment programs and how such programs might evolve over time. For some of these practices, joining with a larger organization was seen as providing a general sense of security no matter what payment programs might be introduced. Okay, so physicians want to clinically integrate, and they want to be able to negotiate with managed care. They can collectively negotiate if they are clinically integrated, and they won't be considered a cartel engaged in price fixing. But they have to meet the government standards on clinical integration. In the alternative, it's been thought that, and this was primarily groups of physicians in the state of Connecticut, embarked on an experiment to see if the government would treat them as employees of health insurers, given the fact that health insurers are monopsonists and can make demands of physicians that are just like General Motors asking the United Auto Workers, and that the relationship was like that. It was quasi-employment. And so that if they would be treated as employees and could be in bargaining, it seemed as bargaining as employees, they would be entitled to an antitrust exemption under the federal law. And so they sought, even though their only relationship was with a large health insurer, they sought recognition as a formal union. And in a very interesting case that was decided by the Labor Board, it turns out that the relationship between a health insurer and the physician doesn't make the physician an employee, and therefore the physicians in Connecticut that were negotiating collectively were investigated by the Department of Justice, and they agreed to discontinue their joint negotiations. But the important thing that the AMA is considering now is that given the fact that the employee segment of the physician market is growing, and even though it's still under 10%, the question is, can physicians join a union and collectively negotiate? And of course the answer is yes. If you're an employee, you can do that. The only caveat is that you can't join a union if you're a supervisor, and depending on what your responsibilities are, the physician's responsibilities are, he may be deemed a supervisor and then excluded from that. Many physicians don't like the idea of a union and like to think that think of their collective concerns as employees in terms of their being a professional association of house staff. And are they enabled by the labor laws to engage in concerted activity that would be protected by the labor laws? What's the answer? If you're an employee and as a physician and members of your medical staff all get together and negotiate for better nursing coverage or better facilities, hours and wages, if you negotiate with those things collectively, can the hospital say, stand down from this concerted effort and discharge you? Are you protected or not? You're not a labor union. You're not in a union. And the answer is that the answer is yes, you are protected. Okay. The NLRA protects non-union as well as union employees in any concerted activity relating to the terms and conditions of employment. And this particular case involves psychiatrists at Bellevue in New York, and they were negotiating collectively. The hospital discharged some of the psychiatrists for their collective negotiations, and the National Labor Relations Act came in and reinstated the discharged doctors. Now, I want to close my remarks on another area that really involves manpower, the labor market in physician services. And how many of you are familiar with the Supreme Court just decided the North Carolina Dental Board case? All right. Well, let me back up a little bit. You are aware that there are scope of practice issues in healthcare. What's the big scope of practice issue here in your specialty? Huh? Multiple? Okay, well, you're physicians and you do certain procedures. Are there non-physicians who want to do some of the things that you've been trained to do? Okay, and your society and others, I imagine, have expressed concerns to state licensing boards as to whether certain non-physicians can perform service, right? And the boards, you want to think that the licensing boards will fearlessly do their jobs, and the medical board hopefully will see things your way and support you. But what's the new concern? This term, the Supreme Court has decided that the antitrust laws apply to, if you will, concerted refusals to deal with or excluding people from a marketplace. And if the licensing board exercises its authority to exclude a group of practitioners, they are now vulnerable to being sued for trouble damages, attorney fees in the large marketplace affected by the exclusion unless the state has actively supervised the board. I should qualify this and say, this rule only applies to boards comprised of where the majority of the board, the licensing board, are active market participants. That is, if the majority of the licensing board, medical licensing board, are doctors, they're in the marketplace, they're considered to be interested, And so their decision to exclude another practitioner under a scope of practice decision will subject them to antitrust liability unless some other agency of the state actively supervises the decision, meaning that meaning that they not passively but actively actually concur that the decision is pursuant to the policy of the state in protecting the public from a non-physician providing certain services. Yes.
Can you just give a couple of details of
What happened in that case?
what was a dentist or dentist trying to do?
Oh yeah, thank you very much. Yeah, I'd love to. Okay. All right. The dentists started doing teeth whitening services. And many of the dentists on the state licensing board were giving teeth whitening services, and it was a lucrative portion of their practices. Okay. Then a few years back, others decided to enter the market for teeth whitening services, and they opened up a cottage industry in parking and shopping centers. And the dentists in the marketplace complained to the board and said, hey, teeth whitening services, they're doing it and they're charging less than what we're charging. That's actually what the substance of the complaint was. Put a stop to it. The board went ahead and sent them cease and desist letters, actually intimidated the landlords in the shopping centers to pull their leases and to get out of the marketplace. Well, then what did the teeth whiteners do? The non-dentist teeth whiteners. They went to the Federal Trade Commission and complained. And the Federal Trade Commission came in and tried to get the dental board to move back. They wouldn't do it. The FTC sued them. The Supreme Court took a look at those bad facts and said, you know, this is just a classic example of the licensing process being abused. Rather than protecting people from legitimate safety, issues, we're actually just trying to act in their own self-interest in the marketplace. And under those circumstances, the dental board had to either go to court and get an impartial part of the state judiciary to review it, or perhaps go to another independent agency of government and get somebody to review it and make a decision on the record. And in the absence of that kind of process, you not only lose your immunity, but you're really in bad shape if you get caught in antitrust litigation because your decision will be colored by the fact that you might have facts like you have here that this would never have happened had they gone to court or to an independent agency. So with those remarks, I'm done. I'm going to pass the time over to Mike. Thank you.